Welcome back. In this chapter, we are going to talk about behavioral and psychiatric emergencies and suicide. The topics we're going to discuss are behavioral and psychiatric emergencies and emergency care for behavioral and psychiatric emergencies. In this first section, we're going to talk about behavioral and psychiatric emergencies. So what is a behavioral emergency? So you have to remember we all exhibit a behavior. A behavior is defined as a manner in which a person acts or performs. It involves any or all activities of a person, including physical and mental activity. Of course, behavior differs from person to person and from situation to situation. In fact, normal behavior is quite dependent on circumstances of a person faces. So everyone has good days and bad days. We face tragedy and wonderful situations that require very different responses. We judge normal behavior and based on the appropriateness of a response in any given setting. Behavior is largely defined as by those around us and based on the way that we act usually. So for example, grief would be an appropriate response to a tragedy but would be deemed abnormal when or after months or years it continues to interfere with the day-by-day activity and disrupts the patient's ability to interact with other people. And then a behavioral emergency exists when a person exhibits abnormal behavior within a given situation that is unacceptable or intolerable to the patient, the family, or the community. Frequently, behavioral emergencies involve behavior that is potentially harmful to the patient or to the people that interact with them. So as an EMT, you have to recognize cultural behavior because you have to remember that just because we don't believe in something in our culture doesn't mean that somebody else doesn't in their culture. Behavioral conditions require a full patient assessment and you have to remain objective because if you start judging, that gets very dicey and it's not okay. So recognizing cultural behaviors, even though you may not believe in it or agree with it, you have to remain objective. So behavior and brain chemistry. So the behavior that you see on the outside is largely controlled by neurotransmitters inside the body, specifically the brain. Medications that target these behavioral conditions help maintain proper levels and interactions of the neurotransmitters. So it's observable behavior that's largely controlled by the neurotransmitters. So it's inside the brain, they travel from neuron to neuron, and impulses move across the nervous system by this mechanism. So neurotransmitters or the lack of neurotransmitters have been implicated in depression and other behavioral and psychiatric disorders. So they do prescribe medications for these conditions, which are designed to affect the relevant neurotransmitters. So newer medication often reuptakes the inhibition of more than just one neurotransmitter. Psychiatric conditions. So some but not all behavioral emergencies are caused by a psychiatric condition, which may also be called mental disorders. So almost 1 in 5 adults in the United States has some sort of mental health illness. So mental health services are declining across the United States or even the world for that matter. And what they do have is very overcrowded. So the more patients that we see with mental illnesses are in the community, but they have minimal treatment. So where does the problem come in? It comes in because there's not help out there for all these people. So this makes it more likely that they will be seen as a patient by EMS systems. So you may be coming in contact with these patients much more often now than what you had in the past. Physical causes of altered mental status can be medical and traumatic conditions that can alter a patient's behavior, which includes low blood sugar, lack of oxygen, stroke or inadequate blood to brain, head trauma, seizures, mind-altering substances, and environmental temperature extremes. Next, we're going to talk about situational stress reactions. So when faced with severe unexpected stress, most patients will display emotions such as fear, grief, and anger. These are typical stress reactions at an accident scene and are common reactions to serious illnesses and deaths. So as you begin to take control of a situation and treat the patient as an individual, your personal interactions with that patient will inspire the confidence in your ability to help them. So the patient will begin to calm down and may even feel able to cope with that emergency that they're in. So be as unhurried as you can. So don't rush. But if you do rush your patient assessment and interview, patients may feel like the situation is out of control. So they always react to you as the caregiver. If you're stressed out and freaking out, the patient is going to be doing that same thing because they're not going to have that confidence in you that you're able to maintain and take care of them as a human. So again, just take into consideration your reactions. Whenever you care for a patient who is displaying typical stress reactions, act in a calm manner, giving the patient time to regain emotional control. You want to quietly and carefully evaluate the situation, but keeping your own emotions under control. You want to communicate that you are listening to what the patient is saying and honestly explain things to the patient. Stay alert for sudden changes in their behavior. So by acting in this manner, you're applying a crisis management technique to help the patient deal with stress. So if the patient does not begin to calm down and if there are no apparent medical causes for the behavior, you must assume that there is a problem of more serious psychiatric nature. So proceed according to the recommended protocols and segments in your local protocols, what your medical director and so forth says, and then different things that you've learned throughout this chapter in this course. Next, we're going to talk about acute psychosis. It involves a severe break in the patient's ability to process information and interact with their environments. It's often associated with a psychiatric disorder such as schizophrenia. So when acute psychosis occurs, that's when the patient develops one or more of the following symptoms. It can be hallucinations, delusions, catatonia, or profound thought disorder. So what are these? Hallucinations are inappropriate sensory observations such as vision or voices. So when you hear auditory hallucinations, that's when people are hearing voices, and it's typically an acute psychosis from a psychiatric cause. The other one is visual hallucinations, which can occur with acute psychosis, but they can also be associated with medical causes such as drug intoxication or alcohol withdrawal. Delusions, however, are falsely held beliefs such as paranoia, and the belief is one being persecuted when that is not necessarily the case. Catatonia is characterized by either an almost complete non-interaction with the environment or wild and completely inappropriate movements and interactions. Finally, the thought disorder. So that impacts the patient's ability to process information and to communicate and can cause unusual speech and or strange writing. The patients are suffering acute psychosis can be particularly challenging as they don't interact or respond as they would normally. Stimuli from the hallucinations or delusions can actually cause severely erratic behavior. Great care should be taken not only to ensure the safety of the patient and the responders, but also to provide a sense of calm and gentle control to an otherwise out of control situation. In this section, we're going to talk about emergency care for behavioral and psychiatric emergencies. So what is range of presentations? They're either withdrawn or not communicating. They might be talkative or agitated. They might be bizarre or threatening behaviors or wish to harm themselves or others. Although behavioral emergencies is slightly different, it is generally important to provide a professional and calm atmosphere. So in many cases, your actions will serve to you to de-escalate an otherwise out of control situation. So providing caring and compassionate setting while maintaining control is essential. So some key techniques to consider are to identify yourself and your role. Speak slowly and clearly and use a calm and reassuring tone. Make eye contact with your patient. Listen to them and show that you are listening by repeating part of what the patient says back to you. And don't be judgmental. Show compassion, not pity. Use positive body language. Avoid crossing your arms or looking uninterested. Acknowledge the patient's feelings. Do not enter the patient's personal space. You want to stay at least 3 feet from them. Making them feel closed in can actually cause an emotional outburst. You want to be alert for changes in the patient's emotional status. Watch for increasingly aggressive behavior and take appropriate safety measures. And use restraint to prevent harm if necessary. So you want to plan your approach to the patient in advance and remain outside of the range of the patient's arms and legs until you're ready to act. So just remember, a fifth rescuer, if available, can control the patient's head and taking special care, however, not to be bitten. So with your patient assessment, you want to perform your scene size up, identify yourself and your role, complete your primary assessment, perform as much of a detailed examination as possible, and gather thorough history. Common signs and symptoms are going to be panic or anxiety, unusual appearance, disordered clothing, or poor hygiene. They could be agitated or unusual activity, unusual speech patterns, bizarre behavior or thought patterns, suicidal or self-destructive behavior, and violence or aggressive behavior. You want to be alert for personal or scene safety problems. Treat any life-threatening problems. Consider medical or trauma causes. Spend time talking to the patient. Encourage them to discuss their feelings, but don't ever play along with their hallucinations. And consider involving their family or friends. Next, we're going to talk about suicide. It is the 10th leading cause of death in the United States. Depression coupled with successful suicide has reached alarming levels in combat veteran and senior citizen populations. Many more people suffer both physical and emotional injuries in unsuccessful suicide attempts. Anyone may become suicidal if emotional distress is severe enough. People attempt suicide for many different reasons. Potential or attempted suicide. So you need to explore the following possibilities. Was there depression, high stress levels, either current or recent? Was there any recent emotional trauma? This is going to typically be between the ages of 15 and 25, and then those over 40 are at the highest risk. And then if there's any drug or alcohol abuse. Has there been previous threats of suicide? Did they have a suicide plan? Previous attempts or threats, and sudden improvement from depression. Your first concern must be your own safety. In the emergency care, you want to do your scene size up, identify any life-threatening problems, reassure the patient, perform secondary assessment, and this would be a detailed exam only if it is safe to do so. Reassess frequently and notify the receiving facility. So something to think about. The patient is a 23-year-old male. His girlfriend called 911 after a domestic dispute. He is uncooperative and refusing treatment. The girlfriend reports patient is depressed and suicidal. He owns a gun and has threatened to shoot himself. So what are some things that you need to think about in this situation? So if you get this 911 call where you have a 23-year-old male, they had a domestic dispute, he's uncooperative and refusing treatment, but the girlfriend reports that he is depressed and suicidal, he owns a gun and threatens to shoot himself. That is not something you're going to go into by yourself. That is something that you should wait for law enforcement to arrive and then give you the all clear. Even if he happens to say, okay, I'm going to cooperate now, once he gets to that point of saying he's uncooperative or refusing treatment, you do not go into that scene unless you have law enforcement with you. So here's some things to think about, and this would also be another good time for you guys to review your protocols of the said department that you'll be working for. But the questions are, can you treat the patient if he or she did not call? Should you believe the girlfriend in what she's saying? Does the patient need treatment or transport? Can you actually treat the patient and transport against his or her will? And what should you do? So these are all questions that you should think about, and this should be a good indication of what you can and can't do. And this is where I highly recommend talking with your medical director, reading your protocols, and knowing and understanding what you can and can't do in situations like this. Next, we're going to talk about aggressive or hostile patients. So you want to consider clues. What does your dispatch information give you? How about clues from the scene? So when you're driving up to the scene, what are you looking for? What do you see? Is there information from neighbors, family, or bystanders that might be outside saying don't go in there, or he's really upset, or he's got a gun, or he's got a knife, or whatever. And then patient stance or position in a room. So if the patient is clenching their fists, and huffing and got a really mean look on their face, I'd probably back out of that room. You want to ensure your escape route. Do not threaten the patient and stay alert for any weapons or of any type. Doesn't matter if it's a gun, a knife, it could be a bottle, it could be a hammer, it could be anything that they could grab a hold of that could be a weapon to hurt you. During your patient assessment, you may not proceed beyond primary assessment until the patient is calmed or restrained. You may spend most of your time calming the patient and assuring everyone's safety. Hostility or aggression never is an excuse for not assessing the patient as thoroughly as possible. So with the aggressive and hostile patients, your emergency care should be performing that scene size up, requesting additional help if necessary, seeking advice for medical control if needed, watch for any sudden changes in behavior, reassess frequently, and then consider the restraints. However, you need to make sure you check with your local protocols as to what type and what kind of restraints that you are able to use. Next, we're going to talk about reasonable force and restraint. So reasonable force is the force necessary to keep patients from injuring themselves or others. Reasonableness is determined by looking at all circumstances involved, including the patient's strength and size, the type of abnormal behavior, their mental status, and available methods of restraint. Understand that you may protect yourself from the attack, but otherwise you must avoid actions that can cause injury to that patient. So again, reasonable is determined by the patient's size and strength, their behavior, their mental status, and the available methods of restraints. In most localities, restraint is within jurisdiction of the law enforcement. Never attempt restraint without proper legal authority and sufficient assistance. If you can't restrain them on your own and it's only you and your partner, you need to wait for more help. The next one is excited delirium. So it's the medical literature that refers to a condition called excited delirium, also agitated delirium. So in this situation, a patient begins to act extremely agitated or psychotic. The triggers for this condition can cause uncontrolled psychiatric illness or drug intoxication. And these patients frequently develop significant and even life-threatening cardiovascular and metabolic stress. So patients with excited delirium can cease and struggling, and often within minutes the patient is found to have inadequate or absent respirations and then suddenly suffers cardiac arrest. So it is important for you to be alert of the sequence of events if the patient exhibits this behavior and to monitor the patient constantly throughout the call. Next is positional asphyxia. So it's inadequate breathing or respiratory arrest caused by a body position that restricts the breathing. You want to carefully monitor all restrained patients. When restraining a patient, you want to make sure that you have adequate help, that you have a plan of action, stay beyond the patient's reach until that you are prepared to restrain them. You're going to act quickly. Just one person is going to talk to and calm the patient down. It requires 4 persons at least. So one is on each limb, so one on each arm, one on each leg. And then restrain all limbs with the approved leather restraints in a supine position, always, never in a prone position. So you want to monitor your restrained patient constantly throughout the call. So you're going to use multiple straps or other restraints to ensure that the patient is adequately secured. You're going to anticipate that the patient's behavior may turn more violent, and you want to be sure that the restraint is adequate for this possibility. If the patient is spitting on rescuers, you want to place a surgical mask on the patient if they have no breathing difficulties or the likelihood of vomiting. And again, only if your local protocols permit you to do so. Or if you have another option is to have rescuers wear the protective mask, eyewear, and clothing, and it might be the best in this type of situation. You want to reassess the patient's distal circulation frequently and adjust the restraints as safe and necessary if distal circulation is diminished. You want to use sufficient force but avoid any unnecessary force. And advanced life support providers may be able to administer medication to help sedate the highly agitated and restrained patient. Furthermore, you also want to document the reason the patient was restrained and the technique of restraint. And you want to have that clearly stated and documented. And again, it is the factual information, not your opinion. Transporting to an appropriate facility. So your medical protocols or procedures should direct you to the most appropriate medical facility within your service area. Not all hospitals are prepared to treat behavioral emergencies. So again, always choosing the correct possible facility with the capabilities. A patient who refuses emergency care or transport is a significant medical and legal risk for the EMS agencies and the EMTs. What should you do when a behavioral emergency patient refuses to resist your efforts to provide care? So most states have a provision in the law that allows patients to be transported against their will if they are a danger to themselves or to others. So this is an exception to the rule that patients must provide consent for their care and transportation. So knowing your state laws is very important, and to understand if they can provide treatment without their consent. So many states do give the authority to law enforcement personnel, and it will always be beneficial to have law enforcement present if the patient must be restrained as a matter of safety. In some situations, you may have emotionally disturbed patients that sometimes accuse EMS personnel of sexual misconduct. So if possible, EMTs of the same sex as the patient should attend the emergency care of the disturbed patients. For the aggressive or violent patient, you want to make sure that law enforcement officials accompany you to the hospital to protect you and the patient. In the event of a legal problem, they can serve as the third-party witness. If you have any questions about this, I would go back and review the medical, legal, and ethical issues chapter just so you kind of have a little bit more understanding and hopefully answer more of your questions. All right, let's do a quick chapter review. As an EMT, you will respond to many behavioral emergencies. Be sure to ensure your own safety before entering a scene or caring for a violent or potentially violent patient. A considerable portion of the population has a diagnosable psychiatric condition. However, not all patients are violent. It is important to remember that patients in crisis are patients and people who need you and your compassion as well as your care. You always want to consider patients acting in an unusual or bizarre fashion to be experiencing an altered mental status. This will help you avoid overlooking a medical or traumatic cause of the patient's problem. Because treatment of these patients usually require long-term management, little medical intervention can be done in the acute psychiatric situation. However, the way that you interact with the patient during an emergency and assess your patient throughout the call is crucial for the patient's continued well-being. You always want to remember that safety is the first priority when approaching a patient with an altered mental status. Psychiatric and behavioral emergencies are prevalent in our society. EMTs should treat them as they would with any other potentially life-threatening disorder. Assessment of altered mental status should rule out physical causes first. Psychiatric and behavioral emergencies can present differently depending upon the disorder. There are best practice EMTs employ in approaching, assessing, and treating such patients. You want to follow local protocols and use appropriate procedures to restrain patients when necessary. A few questions to consider. What methods help calm the patient suffering a behavioral or psychiatric emergency? What can you do when scene size-up reveals that it is too dangerous to approach the patient? And what factors help assess the patient's risk for suicide? Critical thinking. You respond to an intoxicated minor who is physically aggressive, threatens suicide, and whose parents permit you to treat but not transport the patient. How would you manage this patient? First and foremost, safety is number one. At what point do you want to call for police presence? I would call for it right away. Next, you want to calm that patient and then do an actual assessment and treatment. Talking with the parents is very important, as well as completing documentation of the run, signed and witnessed refusal form, and so on.